Critical thinking and coding tips for Chapter 15. Okay, our first critical thinking question: how is uncontrolled hypertension coded? And our answer: there is no code for uncontrolled hypertension. It indicates only that the hypertension is in an uncontrolled state. Malignant hypertension is classifiable and can be coded if the physician states malignant, necrotizing, or accelerated hypertension. Now, this condition is distinguished by symptoms of progressive heart failure, vision impairment, ocular hemorrhage, and papilledema, which meaning this is always associated with malignant hypertension. To report malignant essential hypertension, use code 401.0. Our next critical thinking question: if a patient has both acute myocardial infarction and an old myocardial infarction, can both be coded? And our answer is yes. It's appropriate to code both myocardial infarctions. The acute MI will have a fifth digit of 1, 410.x1, and if the old myocardial infarction is within 8 weeks and is still being observed, evaluated, or treated, and it has been initially treated previously, use the fifth digit of 2, 410.x2. Now, if the MI is beyond 8 weeks old, use the code for the old MI, which is 412. And our last critical thinking question: what challenges are associated with coding heart failure? And the answer: if a physician has documented congestive heart failure, review the record for mention of hypertensive heart or hypertensive heart and renal disease. If the documentation supports these conditions, use a combination code from category 402 or 404. If a patient is in the hospital for something unrelated to the heart failure, but the heart failure is noted to be under treatment, such as patient is on Lasix, the heart failure should be coded as a secondary diagnosis, as it meets the guidelines for coding secondary conditions. If pulmonary edema or fluid overload is mentioned in conjunction with heart failure, they are not coded separately because they are a component of the heart failure. Try to narrow down the exact coding by looking to see if the heart failure is defined as systolic, diastolic, compensated, decompensated, or perhaps to what the heart failure is due to, such as cardiomyopathy or rheumatic fever. Now, often the cardiology consult is the place to find this documentation. Okay, next we'll discuss the coding tips for this chapter. Now, how cardiomyopathy is coded. If the documentation states ischemic cardiomyopathy, use the code 414.8. If the etiology of cardiomyopathy is unknown, code 425.4. If the documentation states hypertrophic obstructive cardiomyopathy, code 425.1. To code any secondary cardiomyopathy, code the underlying disease first and then the myopathy. Now, the relationship between renal disease, heart disease, and hypertension. There is an assumed cause and effect relationship between renal disease and hypertension. Acute renal failure and hypertension does not have a combination code. Therefore, two separate codes must be reported for both of these conditions, 584.9 and 401.9. However, the same is not true of heart disease and hypertension. The physician must document heart disease due to hypertension for the combination code to be used. Now, heart failure. Heart failure is defined as an abnormality of heart function and is the inability of the heart to pump blood at an adequate rate. Congestive heart failure is a typical manifestation of myocardial infarction. when heart failure is present with rheumatic aortic and mitral valve insufficiency, the heart failure is always coded as rheumatic. Continuing on with coding tips, differences between coding an embolism and or thrombosis versus stricture of an artery. The code 444.XX is used for a partial or complete acute onset obstruction of an artery. A thrombosis is the formation of a blood clot within the lumen of the artery that is usually described as a sudden onset of severe pain, coldness, numbness, and pallor. Again, acute onset is the key to using the 444.XX codes. Now, code 44.7 is used to describe a chronic stricture due to various conditions such as atherosclerosis or peripheral vascular disease. There is usually a low insidious development of ischemia and symptoms such as pain, cramping, or a tired feeling that occurs while walking that is quickly relieved by rest. Now, the term stroke versus TIA. A stroke is the layman's term for a cerebrovascular accident. This can be specified as hemorrhagic, embolic, or thrombolytic. There are usually residual neurologic problems that remain. Assign the specific code for each as documented by the physician. A TIA is a transient ischemic attack. It typically resolves within 24 hours. There are no residual conditions after a TIA. Okay, continuing on with coding tips. The difference between phlebitis and thrombophlebitis. Phlebitis is an inflammation of a vein. Thrombophlebitis is a partial or complete obstruction of a vein with resulting inflammation in the wall of the vein. Now, a patient will receive a series of radiology tests, including contrast venography and Doppler ultrasound. These tests will determine whether the phlebitis is a result of a superficial and or deep vein thrombosis. For superficial thrombosis, the patient will require no specific therapy except therapy to relieve discomfort. This may include warm compresses over the painful veins. For thrombophlebitis and DVT, the therapy must prevent pulmonary embolism. The patient will have his or her foot elevated while in the hospital and be given heparin to relieve the obstruction in the vein. If clinically indicated, a patient may receive a surgical interruption of the vena cava, the IVC filter, to prevent pulmonary embolism. And finally, review the codes for the following scenario. The physician's final progress note states hypertensive renal disease and chronic renal failure and end stage due to diabetes type 2. 250.40 for the diabetes with renal manifestation. 403.91, which is hypertensive chronic kidney disease with end-stage renal disease, and 585.6 for end-stage renal disease.